Good morning. Seno thanks all of you for getting up early to hear about Opto-Acoustics. I'm going to present what our device is. It's called Imago. And the first question any device manufacturer needs to answer is whether this is for screening or diagnosis, because they're completely different problems, as we know. And this is clearly an adjunctive diagnostic device. That's what its FDA approval is for. And by the way, the Imago did receive FDA PMA approval in January of 2021. So what is the rationale for Opto-Acoustics? Well, we breast imagers rightly recognize that the cost of a false negative is much greater than the cost of a false positive. So we've tuned our way of reading to achieve very high sensitivity and a very low false negative rate, but that's come at the cost of a relatively low specificity, a lot of false positives, and a lot of biopsies of benign lesions. And the truth of the matter is there's so much overlap in the morphology of benign and malignant masses that using morphology alone from whatever imaging modality is probably never going to get us better specificity without sacrificing sensitivity. So since morphology alone can't really improve our specificity without sacrificing sensitivity, it seems apparent that we need to add a functional component to our imaging. Now, there are other fused functional and morphologic imaging modalities like PET-CT, PET-MR, and even multiparametric MR. But these are expensive or require contrast injection or radionuclide injection or use ionizing radiation. So the development of OA was to try to come up with a fused functional and morphologic imaging device that's lower cost, smaller size, and generally more available. Now, optics or photonics could have been combined with MR or CT, but Seno actually convened a clinical advisory board way back in the early 2000s and offered the possibility of combining photonics with MR or CT or ultrasound, and the panel universally chose ultrasound because of its lower cost, smaller size, and increased availability. Now, what Opto-Acoustics is two kinds of fusion. It's a fusion of modalities, which is laser light in and ultrasound out, and we'll explain how that works later, but also function and morphology. Now, why does Opto-Acoustics work, or why would it help in a functional component? Well, we know that cancers can't grow beyond about 2 millimeters in size without generating neovascularity. And we also know that cancer cells are generally metabolically more active and deoxygenate blood more than normal tissues or benign tumor cells. And OA can demonstrate the neoangiogenesis that occurs within and around invasive malignancies. And the around part is very important because most of the angiogenesis is not within the hypocoax central nidus. And Opto-Acoustics can also demonstrate the relatively greater degree of deoxygenation that occurs within and around invasive malignancies. And finally, OA can also demonstrate the size, shape, and orientation of blood vessels, whether they're native or neoangiogenesis vessels. So exactly what is Opto-Acoustics? Well, in a very brief explanation, very brief low energy laser light pulses are sent into the breast, and they're absorbed primarily in hemoglobin. So when they're absorbed in hemoglobin, it expands. So the blood vessels that hold the hemoglobin expand. The expansion is thermoelastic, and it creates a pressure wave that goes back to the ultrasound transducer. And when it gets back to the transducer, it's recorded as being ultrasound. So this is sort of an illustration. We send in the light, it causes thermoelastic expansion, that creates a pressure wave that comes back to the ultrasound probe, the transducer, and is interpreted as being an ultrasound wave. So it's laser light in, ultrasound out. Now we can fire about 10 pulses per second, not because of computer limitations, but because we have to allow enough time between pulses for the heat, the slight heat that's generated, to be dissipated by diffusion and or be carried away by flowing blood. But to generate a frame of OA, we need both a long wave and a short wave, waves that are designed to be absorbed in oxygenated, deoxygenated blood. So we can essentially generate 5 frames a second of OA, and each frame takes about 200 milliseconds to create. This is the Imago machine on the right. it looks like an ultrasound machine, but about 2/3 of what's in there is laser equipment, and only about 1/3 is ultrasound. So it's even though it's the size of an ultrasound box, it's significantly heavier. This is the duplex probe shown in the bottom center, and it has two cords coming out. One is the ultrasound bundle, and the other is the laser optic fiber bundle. On the top center, I'm showing you a picture of the face of the probe. The ultrasound transducer is in the center, and there are laser windows on either side out of which we send laser light. Also notice that this machine has a dedicated ultrasound-only probe, a 14 megahertz, 5 centimeter linear transducer. And that's important because there's no real purpose of turning on Opto-Acoustics if you have a BI-RADS 1 or 2 ultrasound. The negative predictive value of BI-RADS 1 or 2 diagnostic targeted ultrasound is 99%. So basically we save the Opto-Acoustics for solid or complex cystic and solid masses that are BI-RADS 3, 4, or 5 by ultrasound. So again, we got a dual fusion of modalities, laser light in and ultrasound out, and of morphology and function. And obviously we get some morphologic evaluation from the grayscale ultrasound component, but also the demonstration of tumor neoangiogenesis vessels and their size, shape, and orientation. And the function comes primarily from the OA demonstration of relative degree of deoxygenation. Now we use two different wavelengths, and there's no point in your memorizing the nanometer wavelengths. We just call them OA shortwave and OA long wave. And basically the brown curve is deoxygenated blood. And you can see that our shortwave is at the peak absorption for deoxygenated blood. And then we can see that the long wave, the 1064, is a little bit past the red peak of oxygenated. But the important thing here is not where the peak is, but the difference between oxygenated and deoxygenated curves, and also to avoid the confounding water peak, because there's a fair amount of water in the breast. This is an image of the face magnified. It's a 38 millimeter transducer. Gen 2 will be a 50 millimeter transducer. It's important to know that both wavelengths are fired out of both windows. It's not like one wavelength is fired out of one window and the other wavelength fired out of the other. The 50 millimeter transducer will be an improvement because in breast imaging, we prefer to use a longer transducer if we can. This is how the display is. It's a 6-on-1 display. The grayscale ultrasound images in the left upper corner, and then there are 5 different OA maps. And we'll talk about what each of those is. The upper right one is a shortwave, so that's going to show primarily deoxygenated blood. And things that are brighter on that map are going to be coded red. So red is for deoxygenated. And then things that are brighter and sharper on the long wave map are going to be colored green. So basically we have a spectrum that goes from oxygenated at green aqua to deoxygenated at red fuchsia. Now what we learned is that even though in this case we see plenty of polymorphic deoxygenated vessels within the hypoechoic central nidus of the lesion, we learned that in many lesions, and particularly grade 1s and luminal A's, there's not much going on in the hypoechoic central nidus. Most of the angiogenesis is actually outside the hypoechoic central nidus within the thick echogenic rim. And in benign lesions, there are draping vessels that occur along the capsule. So basically, we divide a lesion into 3 zones: the internal zone, which corresponds to the hypoechoic central nidus; the boundary zone, which corresponds to either the thin echogenic capsule or the thick echogenic rim that surrounds lesions; and the peripheral zone is just whatever is outside of that. But we're going to show you that the bulk of the angiogenic findings occur in the boundary zone and to some extent the peripheral zone. And the distribution of these vessels can help us decide whether it's high grade, low grade, what the receptor status is, and molecular subtypes even. So in real time, we're generating the grayscale ultrasound image in the left upper corner and the 2 raw grayscale optoacoustic wavelengths. These are generated as natively acquired frames. Now, the next thing we do is we do a quick mathematical calculation in real time, compare the long and short wave, and if things are brighter on the short wave, they're colored red, and if they're brighter on the long wave, they're colored green, and we display it in this second map, the OA relative map. That's our most sensitive map. Notice that there's a fair amount of colorization in the background. So we can do some thresholding or filtration like wall filter on a Doppler to screen out some of the background noise. And the next one we create is this OA total image. So that doesn't distinguish oxygenated from deoxygenated. It actually adds all the hemoglobin together and creates a total hemoglobin. And then that's used as kind of a subtraction mask on top of the OA relative to create the OA combined. And all this is happening in real time. This is being generated in real time at 5 frames per second in OA. The ultrasound frame rate obviously is going to be faster. It can be 15 to 30 depending on depth and settings like spatial compounding and speckle reduction. Now, an important thing we learned is that the angiogenic changes are not at all uniformly distributed, and it's quite common that they're mostly outside the lesion and mostly along one side of the lesion. So if you just get 2 orthogonal still images, radial and anti-radial or longitudinal and transverse, through the widest part of the lesion, as we do to make measurements, you may not see much within the beam. And what you see may look like a draping capsular vessel, so you may get a false negative. So we found that it's very important to store orthogonal video loops along the short axis of the transducer. And by making that video sweep, we can show these eccentrically located vessels in the boundary zone and the peripheral zone. This is an example of a luminal A grade 1 small tumor. It's about 7 or 8 millimeters. And we can see that maybe if you look at the yellow map in the left corner, left lower corner, maybe we see a peripheral radiating vessel there, a boundary zone vessel there, but it's questionable. At best, on our scoring system, that would be 3 out of 5. This is the still image that was taken for purposes of measuring the lesion. This is the video loop through the lesion. You can clearly see that there are numerous long segments of radiating vessels. I'm just performing, we're performing a short axis video sweep across the lesion, but on the video, both the boundary zone and peripheral zone would be scored maximum, 6 out of 6 for boundary zone and 5 out of 5 for the peripheral zone. So the likelihood of malignancy is much higher on the video loop than it is on the still image. Now, people want to think about OA as being a super Doppler, but it's not at all like Doppler. The only similarity is that they both show blood vessels. But Doppler has several limitations. It's angle independent, whereas OA is not. Doppler works best at 0. It doesn't work at all at 90. OA doesn't care about the angle of incidence. Doppler requires a certain critical velocity. If blood flow is too slow, you can't see it on Doppler, like you can't see a Doppler signal in a placental lake, but you can see the flow on grayscale. Well, OA doesn't require any critical velocity, it can show stationary blood. The biggest difference, I think, is that OA has a very high contrast ratio, anywhere from 6 to 20 to 1, whereas Doppler has a terrible contrast ratio of 2 to 1, and that's significant because of volume averaging. For a blood vessel to show up on Doppler, it pretty much has to be large enough to fill an entire voxel. On ultrasound, on OA, on the other hand, a blood vessel could fill 10% of a voxel, and if it starts with a contrast ratio of 20 to 1, even if it's only filling 10% of a voxel, that voxel will still light up at 2 to 1. So it means that we can see much smaller vessels on OA than we can see on Doppler. And we know from histologic correlations that we often see vessels in the 80 to 100 micron range in the optimal focal zone of the transducer. And then the last thing is that OA shows a relative deoxygenation, which Doppler can't show at all. Now, on the left, both of these are the same lesion. This is a 6 millimeter grade 2 invasive ductal cancer. This is actually a luminal B. And we can just see a single vessel on Doppler, but on OA, there's a deoxygenated blush filling the entire internal zone, an deoxygenated red blush in the boundary zone, and multiple green radiating vessels. So that degree of discordancy between what Doppler shows and OA shows is not at all unusual. It's typical. Now, to be effective, OA has to be able to diagnose a range of different molecular subtypes of small screen-detected cancers. If it only worked on 3.5 centimeter palpable cancers, we wouldn't be accomplishing much. Our goal is to reduce the resistance to screening mammography by reducing our false positives. And so basically this needs to work in small lesions. So on the top left, we're showing 8 millimeter grade 3 triple negative. And you can see that it's intensely positive in the internal boundary zone. On the right upper corner, we're showing a 4mm grade 1 luminal A. And notice that it's completely negative in the hypoechoic central nidus, but it's got a blush in the boundary zone and multiple peripheral radiating vessels. So it's positive in the boundary zone, peripheral zone. And then the bottom is a 6mm. This is actually a grade 3 luminal B, and it's positive in all 3 zones. And so you can see that the distribution is different here, and we'll talk more about that later, but we can actually predict the histologic grade and ER status and Ki67 and molecular subtype from these things. Now, those of you who read MR, which is basically all of us, know that if the morphology and the kinetics agree, we don't have an issue. But if there's a discordance between the kinetics and morphology, we have to make a decision which is more reliable. And in MR, I would say that most of us feel that morphology is more reliable. If you have reassuring kinetics, but very worrisome morphology, the lesion is very worrisome. The exact same is true in OA. I mean, basically, red means deoxygenated. The veins are deoxygenated, so veins are generally going to show up red. Green means oxygenated, so arteries are oxygenated better, so they're going to typically show up green. It's not 100%, but that's a general rule. So basically, any living tissue has to have both red and green vessels. So yes, a lot of red is suspicious, but just because you see a red vessel doesn't mean it's suspicious. The morphology here is very reassuring. This is a benign-looking fibroadenoma on grayscale ultrasound. And even though this vessel is red, it's a typical draping, tapering, capsular vein on a fibroadenoma. So the fact that the morphology is reassuring trumps the fact that it's a red vessel. Now we've created a scoring system where we have 3 internal feature scores. These occur within the hypoechoic central nidus, or what we call the internal zone. We look at internal vessels, internal deoxygenated blush, and internal total hemoglobin. They each have scores of 0 to 5. And then we have external features of the boundary zone and the peripheral zone that go from 0 to 6 or 0 to 5. And what we learned is that as breast imagers, we're so focused on the hypoechoic central nidus that we're not seeing the boundary and peripheral zone findings as well. And what we learned is that if we encouraged an outside-in reading pattern where you read the peripheral zone first, then the boundary zone, people could actually see and score the features better. This is just an example of the boundary zone feature score. It goes from 0 to 6, and the likelihood of malignancy goes up as you go up from 0 to 6. I've color-coded these in terms of their PPV3, and you can see that 0 through 2 are basically BI-RADS 4A benchmark PPV range. 3 and 4 are basically upper BI-RADS 4B benchmark PPV range, and the scores of 5 and 6 correspond to lower 4C. We've created image reference keys, so when you score, you can click radio buttons, or you can just click on the image that looks most like what you're seeing. And again, the frames around them, around the outside, the rims, are color-coded by PPV. These are the PPV slopes for the scores, and you can see that in general, the likelihood of malignancy, or the PPV3, same thing, goes up as the scores go up. But I think you can see that the single best, if you define best as starting at the lowest PPV at a score of 0 and having the highest PPV at a score of 5 and the steepest, most uniform slope, then the boundary zone certainly wins. And actually, you can actually look at the area under the curve for the ROC curve and clearly show that the 2 external features, the boundary zone and the peripheral zone, have much higher area under the curve than any of the internal features. And so this validates our enforcing or encouraging an outside-in reading pattern. The danger if you read inside out is that you're going to try to make a diagnosis from the less optimal internal features. Now, we've done a lot of histologic correlation. In fact, in our Maestro study in Europe, we required that every excised lesion be mounted on a 5x7 megacassette, and that the maximum diameter be 3 centimeters, so that we would always have at least 1 centimeter of surrounding tissue to evaluate. And the surrounding tissue was important because, as I mentioned, most of the angiogenesis is in the boundary and the peripheral zone. So here's a case where we're seeing quite a bit of deoxygenation internally, a little bit of deoxygenation in the boundary zone along the right side between, say, 3 o'clock and 1 o'clock, and a little bit over on the left near 10 o'clock. But if we get a histologic specimen right here, This white line that I've drawn is the boundary between the internal zone and the boundary zone. And these white things are big vessels, which I'll color code with the red. And you can clearly see that the richest vascularity is in the boundary zone. There is some vascularity in the internal zone, but in virtually every case, regardless of histologic grade, ER status, PR status, Ki67, molecular subtype, the boundary zone is where the richest neovascularity is located. Now, we know that imaging features can be used as biomarkers, but we also know that single imaging features generally lack sufficient sensitivity to be used alone. And so it's recommended that we use panels of multiple biomarkers. And because our scoring system has 5 separate scores, 3 internal and 2 external, we can assess whether adding them together works better than using them alone by summing the 3 internal scores or summing the 2 external scores, which would increase the range from 0 to 5 to 0 to 15 for the internal scores, and from 0 to 5 or 6 for the external zone to 0 to 11. And when you do this, especially if you look at the external sum of scores, now at a sum score of 0, there's a 0% PPV, and at the maximum sum score of 11, we're 95.5%, which is BI-RADS 5. So the slope is much steeper, it's more uniform. Just visually, you can see immediately when you compare the single best individual feature of OA boundary zone to the sum of the boundary zone and peripheral zone, you can see that by summing the scores, you get more than an additive thing, you get a complementary thing. And we can add all 5 features together and again, show that we have a sigmoid shaped steep curve. Now, this is just an unweighted sum. What I'm going to show you is that the artificial intelligence program we use, the Senogram, properly weights the more robust external features more heavily. We also learned that even though BI-RADS really helps us pretty well decide whether to recommend biopsy or not, assigning a likelihood of malignancy or a false negative rate is difficult because we just guesstimate. There's no objective way to use BI-RADS to do that. So we also created an ultrasound scoring system very analogous to that we use for OA. And again, I'm just showing you just one, the boundary zone feature score. And the boundary zone is what's gone from edition 5 of BI-RADS, but it's really important. And again, we can see the PPVs range from 4A at scores of 0 and 1, all the way up to high 4C for a score of 6. Again, we've created image reference keys, so you can click radio buttons, or you can just click on the image that looks most like what you're seeing. But again, just like for OA, it turns out that the PPV curve is best for the ultrasound boundary zone, where we're going from just a 2.5% PPV at a score of 0 up to almost 95% for a score of 6. And again, if you look at the area under the curve, the boundary zone has a higher area under the curve even than shape. So boundary zone is very important. And again, if we sum the scores, you can see we get a beautiful PPV curve that's got 0% PPV at scores of 0 and 1 and 100% at a score of 26. So we want this low left shoulder and we want a high right shoulder. The low left shoulder is where the BI-RADS 3s lie, and the high right shoulder is where the 4Cs and 5s lie. And 4Cs and 5s just need biopsy. There's not much you need in the way of adjunctive diagnosis there. Now, the fact that the boundary zone is important on both ultrasound and OA shouldn't be surprising because we have other modalities that tell us that. We know on strain elastography, the area of stiffness is theoretically larger than the lesion, but it's really just larger than the hypococcentral-nitis. It's the exact same size as the hypococcentral-nitis plus the thick echogenic rim. And on shear wave, it's the echogenic rim that's stiff, not the hypococcentral-nitis. And the ring enhancement that we see on MR corresponds to the boundary zone. And if we inject feeding arteries and draining veins on a cancer and then dissolve the cancer with acid, we can see that there's not much going on in the internal zone, but the richest neovascularity is within the boundary zone. So we have other evidence that the boundary zone is very important. And it's where the lesion is actively growing and interacting with the surrounding tissue. Now, this is a histologic specimen from one of those 5x7s. And again, the white line on the histologic image is the boundary is the border between the internal zone on the left and the boundary zone on the right. And if I magnify this boundary zone, we can see that the echogenic rim is happening because of things that are infiltrating between fat cells. So there's something insinuating itself or infiltrating itself between the fat cells that creates the echogenic rim. So here we can see tumor cells between fat cells creating some echoes. And here we can see tumor-associated lymphocytes and macrophages insinuating themselves between the fat cells. And here we can see desmoplasia, fibroelastosis, insinuating itself between fat cells. And here we can see a neovessel. So we can see that just on this one slide, there are 4 contributors to this echogenic rim, and that the angiogenesis is mostly in the boundary zone. Now, it's even more complex than that because you have tumor-associated fibroblasts, tumor-associated lymphocytes, tumor-associated macrophages, tumor-associated polymorphic nuclear cells. You can have tumor-associated adipocytes, and then you've got tumor-associated endothelial cells, and there's all this intercell signaling going on. So a lot is happening in that boundary zone. Now, I mentioned that by summing scores, we can create panels that give us better PPV curves than we can get with any individual feature. So I've shown you the sum of the 5 OA scores and the sum of the 5 IUS scores. But what I'm going to show you now is the sum of all 10 scores, the 5 IUS internal ultrasound scores and the OA scores. And now we've got a sigmoid curve with a low shoulder on the left, where to the left here is where the PPV is less than 2%. So those are BI-RADS 3s. And on the right, the PPV is above 50%. So that's BI-RADS 4C and 5. These are cases where we don't need to biopsy. In the middle is the 4A and 4B, where most of our false positives occur. And so one of our goals should be to make the shoulder on the left lower and longer, and to make this 4A and 4B zone narrower, but maintain the width of the 5 zone. Now, Seno has done lots of studies, and these studies include 2,267 masses and approximately 20,000 reads. And these are studies that were done prior to the study for which FDA approval was obtained. That's Reader 02, and I'll give you a brief summary of the results. What we learned is that the scoring system for OA features and ultrasound features is very effective, and radiologists, breast imagers, really had moderate to good interclass correlations, so they can reliably assign scores. But it was more difficult for them to take these 10 feature scores and convert them into a likelihood of malignancy or PPV or false negative rate. And so essentially there was information overload. And so what we did is we employed AI machine learning to help the radiologists deal with this information overload. And so what we do is, with this AI machine learning Senogram, we put 14 different features in: the 5 ultrasound features, the 5 OA features, age, mammographic BI-RADS, mass size, and depth. And we get one output, either a predicted false negative rate if it's less than 2%, or predicted likelihood of malignancy if it's above 2%. The advantage that the machine learning has over simple regression equations is that it can mix and match different kinds of data. So the ultrasound and OA feature scores are ordinal. The age, mass size, and depth are numeric, quantitative. And the mammographic BI-RADS is categorical. And so AI is better at mixing and matching different data types than regression equations. Now, one of the things we did that's a little different from BI-RADS is everything in BI-RADS is just PPV, or likelihood of malignancy. So in the blue curve, we have the PPV, and in the yellow curve, we have the false negative rate. And these are different equations. The PPV is just the percent cancers or the percent not cancer at any individual score, whereas the false negative rate is the number of false negatives at that score and to the left of that score. So they're a little bit different. But if you see, if we use PPV, we get a fairly narrow green zone where we can call things BI-RADS 3. But if we actually switch to false negative rate, it's quite a bit farther to the right. So by having a combination of false negative rate below 2% and PPV or likelihood of malignancy to the right, we can actually achieve something. So left upper corner, I'm showing you PPV alone. And you can see that there's a fairly narrow BI-RADS 3, but a wide BI-RADS 4C and 5, and a fairly wide 4A. We can see if we use just false negative rate, we widen the left shoulder where the BI-RADS 3 lie, but we have fewer 4Cs and 5s. And that makes the 4A and keeps the 4A and 4B pretty wide. But if we use this combination of false negative to the left and PPV to the right, now we've got a wide left shoulder BI-RADS 3s, a wide right shoulder 4Cs and 5s that don't need any adjunctive diagnosis. They just need biopsy. But notice how much narrower the 4A and 4B are, and particularly the 4A. And that's really important because most of the false positives occur in the 4A category. And when we actually assess the performance of the sonogram, the flesh colored dots represent predicted versus actual PPV. And you can see it makes a nice straight line. The red is the false positives. The green is the false positives. The red is the false negatives. And you can see that they go up and down as the predicted likelihood of malignancy goes up and down. But what's really important in gray on the bottom is the percentages of lesions. And so good adjunctive diagnostic tests should move masses out of the BI-RADS 4A and 4B category into the definitively benign and definitively malignant, 5 categories. And you can see that we're shifting the malignant lesions up to the right and the benign lesions down and to the left. Now the sonogram is pretty easy to use. This is the scoring sheet. You can just click the radio buttons, or you can bring up the image reference keys and click on the image reference key that looks the most like what you're seeing, and it'll automatically light up the correct radio button. And then you can just hit next feature and you can score all the way down. When you get all 15 scores in, what you get is a predicted likelihood of malignancy. The blue circle is the mean likelihood of malignancy, or PPV3, same thing. And the blue bar with the hash marks represents the 90% confidence interval from the 5th percentile on the left to the 90th percentile on the right. So this black line over on the left side, the one that goes all the way across that I'm pointing to with my cursor, represents the 2% false negative rate line. So to the left of that, we're doing a predicted false negative rate, and to the right, we're doing a predicted likelihood of malignancy, or PPV3. Each of these little short hash marks is a 0.5%. So in this particular case, you can see that we're at about 70%, 65% mean likelihood of malignancy, with a 90% confidence interval that goes from approximately 50% to 70%. Again, BI-RADS is primarily a qualitative diagnostic biomarker where we're using the ultrasound features to say recommend biopsy. Is it BI-RADS 3 or less, or is it BI-RADS 4A or higher? But we're not really using them objectively to predict a false negative rate or likelihood of malignancy. So the ability to do that is a semi-quantitative biomarker, which is not part of BI-RADS. Now let's just show an example of downgrading with OA. So here's a case where the ultrasound features are on top, and the farther to the left, the more negative or benign they look. But here we have a shape score of 3, which is irregular without angles. 100% of the time, I'm going to call that 4A and recommend a biopsy. So irregular shape without angles is an automatic BI-RADS 4A on ultrasound. But you can see that the OA feature scores are all pretty low. And she didn't have a mammogram because she's under 40. And it was 1 centimeter in size and 1 centimeter in depth. But you can see that the predicted likelihood of malignancy, the entire 90% confidence interval, is to the left of the 2% line. So that's BI-RADS 3. Again, this black line represents the 2% false negative rate. So to the left of that would be BI-RADS 3, to the right of that's 4A or higher. And this one, we're probably at about 1.2% for the mean. And the 90% confidence interval is going from 0.8 to 1.6%, say. So this would be an example of a high 4A. This is about a 10% likelihood of malignancy. And this one is very interesting because the mean false negative rate is clearly below 2%, but the 95th percentile is maybe up at 4%. So you have to ask yourself, am I going to call that BI-RADS 3? Am I not going to? And the answer is, I don't know. It kind of depends on your personality. There's still going to be some art to medicine. So if you're a very aggressive breast imager, you may be willing to call it BI-RADS 3 if just the mean likelihood or mean false negative rate is below 2%. But if you're a conservative breast imager, you're probably going to require the entire 90% confidence interval be to the left of 2%. And I tend to be more conservative, so I would probably call this 4A, because the entire 90% confidence interval is not to the left of the 2% false negative rate. Now, an interesting thing is BI-RADS has correctly said that we can't subjectively assign a BI-RADS 2 category to something we think is a probable fibroadenoma on the baseline exam. Instead, we have to follow it for 2 to 3 years and show stability before we can downgrade it to BI-RADS 2. And I agree with that. But theoretically, BI-RADS 2 carries a 0% false negative rate. The truth of the matter is there's never been a single ultrasound or mammographic article published in which the false negative rate actually was 0%. So probably the most famous is Dr. Sickles' report from Clinics North America, where there was a 0.2% false negative rate for diffuse benign calyx and 0.3% for multiple circumscribed masses. And then Wendy Berg did a study as part of Akron where she showed a 0.5% false negative rate for BI-RADS 2 solid masses. And then Dr. Chan wrote a nice article that used combined mammographic ultrasound, so that's very valuable, and found 0.3%. And the most recent breast cancer screening consortium audit showed 0.7%. That's a little higher than I'd like to use. So, basically the mammographic and ultrasound false negative rate of 0.2 to 0.5 is what's been published for BI-RADS 2. And so the question is, how low a false negative rate would it take for you to be willing to classify a mass as BI-RADS 2? And again, if one were super conservative, you might not ever be willing to do it. But if you're, conservative, maybe you'd want the entire 90% confidence interval to be the left of 0.5%. Or if you're super aggressive, maybe just the mean would be below that. So here's an example of classically benign lesion on ultrasound, classically benign features on OA, a young patient who's too young for mammogram, only 29, a relatively small lesion. And we can see how far to the left the mean false negative rate and entire 90% confidence interval are. When I magnify that, again, this black line is the 2% false negative rate. The leftmost hash mark is a 0.5% false negative rate. And so if the entire 90% confidence interval is to the left of that, you'd say, could you call that BI-RADS 2 on a baseline exam rather than having to follow it for 2 years? I just saw a new article in Journal of Breast Imaging yesterday in which they showed that the cost of follow-up actually was greater than the cost of biopsying these BI-RADS 3 lesions. So if you could call it BI-RADS 2 on a baseline, it didn't have to follow it, then you could change that cost equation. This is just further magnification. So we can see here that my mean false negative rate is probably 0.3% and my 90% confidence interval is probably 0.2 to 0.4%. So the entire 90% confidence interval is to the left. Now, do we have any evidence that this could be done? Well, actually, in our Reader 02 study, the mean predicted false negative rate was below 0.5% in 703 reads, and 700 of those were benign. So the 3 false negatives out of 703 comes to a 0.4% false negative rate, which is within the published 0.2 to 0.5 published range of false negatives for BI-RADS 2. Now, we did look, some radiologists chose to subjectively downgrade things to BI-RADS 2 in earlier studies where the centigram wasn't available. And you can see that we had false negative rates of 2.8% and 11.1%, which shows that the ACR is absolutely categorically and imperatively correct that you should not assign BI-RADS 2 on a probable fibroadenoma on the baseline on a subjective basis. But if you have an objective, a precise way of predicting false negative rate, it'd be something to consider. Now, I'm not recommending you do this. I think more studies need to be done, but it's very interesting data. Now, if we look specifically at categories, if the ultrasound was BI-RADS 3 and the OA downgraded it to less than 0.5% mean likelihood of malignancy, there was a 0.4% false negative rate. But if the ultrasound was 4A and we tried to downgrade it 2 steps to BI-RADS 2, the false negative rate was 0.8%. And if we combine 4A and 3s downgraded to 2, it was 0.5%. Now, the middle category suggests we shouldn't try 2-step downgrades from 4A to 2, but remember, this is the mean false negative rate. And I said that conservative person would only want to downgrade to BI-RADS 2 if the 95th percentile were below 0.5%. And so I'm kicking myself because I didn't run that number. I only ran the mean. So we will see. But again, I'm not recommending anybody do this. I'm just saying it's very interesting because we now have a precise and objective way of assigning likelihood of malignancy to the right and false negative rate to the left, which may change the way we think about this. Now, I want to give you a very brief summary of the data upon which Opto-Acoustics was approved. This was the Reader 02 study. It was an independent reader study. And it included solid or complex cystic and solid masses that were classified as BI-RADS 3, 4A, 4B, 4C, or 5 by conventional ultrasound. In this study, we had a total of 480 masses, 180 malignant, and 300 benign, which is about a 35% PPV, 36% PPV. Now, this was an independent reader study, so even though there are 480 masses, with 15 readers, there were 7,200 total reads, 2,700 reads of malignant masses, and 4,500 reads of benign masses, so a fairly large number. And what this study did is it compared the conventional way that we read ultrasound using the history and the mammogram together with the ultrasound to subjectively assign a BI-RADS category and recommend biopsy or not, versus read 2, which again allowed history and mammogram and the ultrasound features to be combined with the OA features and put through the sonogram to look for its outpat. So basically, we're comparing OA with artificial intelligence machine learning versus just subjective reading of ultrasound alone with mammographic clinical history. The primary endpoint was to show improved specificity at 98% sensitivity. Secondary endpoints were to assess whether OA could improve negative likelihood ratio, positive likelihood ratio, and partial area under the curve corresponding to sensitivities from 95 to 100%. And I specifically want to talk about specificity at fixed sensitivity of 98%, which we call FSP, and partial area under the curve rather than complete area under the curve. The reason for that is that a lot of the difference in the area under the curve occurs over in the knee of the curve at lower sensitivities and lower false negative rates. But, you know, that might be pertinent in a screening population, or it might be pertinent in a diagnostic adjunctive population if high sensitivity was not required. But we make our decision to recommend biopsy at 98% or 2% PPV based upon BI-RADS. Again, BI-RADS doesn't use false negative rate, it uses PPV. But you know, what's happening over here at the knee of the curve may be completely irrelevant in terms of making a decision on recommending biopsy or not biopsy. And so what we do is we look at partial area under the curve from a sensitivity of 95% to a sensitivity of 100%. And so what I'm doing is showing you data from a single reader. And on the left, I'm showing you a complete area under the curve. And it's slightly higher for OA, which is green, than it is for ultrasound. But if you're trying to evaluate how we're doing at 98%, I mean, they overlap each other. You really can't tell what's going on there. When you look at partial area under the curve, you can see that the curve for OA and the sonogram is much higher and farther to the left. And so it's going to have a larger partial area under the curve. Also, if you look exactly at 98%, which is where, you know, we're making our recommend biopsy versus not recommend biopsy decision, you can see there's quite a bit of difference in the specificity at a fixed sensitivity of 98%, which is the width of that blue line with the hash marks. So that's the reason that we feel that it's very important to use specificity at 98% sensitivity and partial area under the curve rather than complete area under the curve. Now, how could that be important? Well, elastography has been around for 15 or 20 years, and it actually works fairly well. I mean, a lot of papers have shown that there's a 20 or 30% improvement in specificity, but they're also showing 10 or 15% loss in sensitivity. And what we've noted is that when you're operating at sensitivities above 95%, it's roughly a 10-to-1 ratio. So every loss of 1 point in sensitivity will neutralize or cancel out a 10% gain in specificity. So if you're gaining 20 or 30%, but you're losing 10%, you've got a net negative. And so the way to deal with the improvement in specificity versus loss of sensitivity is by using this specificity at 98% sensitivity and partial area under the curve. And so when we look at the observed data, the actual observed data, OA improved the specificity from 36.6% to 50.1%, but it did lose about 0.4% of sensitivity. Now, if we look at this, you have to ask yourself, does the gain in specificity outdo the loss in sensitivity? And the answer is you don't know, but when you do the specificity at fixed sensitivity of 98%, there is a 9% gain using one method, and then a second method shows 10.2%. The encouraging thing is that the specificity at 98% sensitivity was better for 14 of the 15 readers. Now, the secondary endpoints were done in a sequential design where the negative likelihood ratio was done first, then positive likelihood ratio, then partial area of the curve. And the sequential design was chosen because it reduces the number of variables, and then it reduces the sample size necessary to achieve statistical significance. Now, when we look at NLR, it did get better with OA from 0.053 with ultrasound alone to 0.047 with NLR. Remember, lower NLR is better, but it wasn't statistically significant. And that meant that we couldn't really run p-values for the positive likelihood ratio or partial area under the curve. But what was impressive is that in this study, the 0.1 is considered a good negative likelihood ratio. And the negative likelihood ratio for elastography, say, is anywhere from like 0.11 to 0.18. So you can see that OA is achieving a much better or much lower NLR. And it was much better than we did in our earlier studies. Now, the significance of a 0.047 NLR is that if you plug it into Bayes' theorem and calculate what's the maximum pretest probability you can reduce to 2% after a negative test, 0.047 corresponds to a 30.3% pretest probability can be reduced to post-test probability of 2% after a negative study. That means that a negative OA theoretically can, based upon Bayes' theorem alone, could downgrade all of 4A and the lower half of 4B, which goes from 10 to 50%. Now, for PLR, the higher the PLR, the better. And again, OA achieved a PLR of a positive likelihood ratio 1.959 versus 1.548 for ultrasound alone. And if you look in the green boxes at the 95% confidence intervals, there's no overlap. So that was good. And the importance there is that a fair number of triple negatives can look relatively unworrisome on ultrasound. So we get some false negative ultrasounds on triple negatives. But if you had a triple negative where the pretest probability on ultrasound alone was 2% and you got a positive OA, that would increase you to lower 4A, so you could avoid some false negatives. And we did avoid some false negatives and triple negatives. Now, the partial area under the curve was improved to 0.0244 with OA versus 0.0205 for ultrasound alone. And again, higher the partial area under the curve, the better. The relative improvement was 16%. And what was really encouraging is all 15 readers had better partial area under the curve with OA than they did with ultrasound alone. So it's 15 out of 15, and that's quite impressive. Another issue with new modalities is inter-reader variation. I mean, ultrasound, especially if you just use 3 categories, BI-RADS 3, 4, and 5, fairly good interclass correlations or inter-reader variability can be obtained. But when you go to BI-RADS 4 subcategories, it drops down to poor or moderate at best. But you can see that we were at 0.8, which is good. So we had good inter-class correlations, good reproducibility. The readers were able to score reliably. And another important thing is if we look at the specificity at fixed sensitivity of 98%, and we plot that versus the years of experience, both for ultrasound and for OA, there's no trend. So it looks like younger, less experienced breast imagers can perform as well as more experienced and older breast imagers with OA. Now, one of the things about the AI machine learning sonogram and any AI machine learning thing is that it can be overtrained on a specific population. So you'd like to know how it does on other populations. So I'll show you two examples of that. This is the first is applied retrospectively to reads from one of our earlier studies, the Pioneer study. And you can see under observed specificity, there was a 13% improvement in specificity, but there was a 1.2% loss in sensitivity. And remember, I said it's about a 10 to 1. So if you get a 13% improvement in specificity, but a 1.2% loss in sensitivity, it's just about going to cancel out. And when you look at the specificity at 98% sensitivity, it only improved from 34 to 35.5%. So a small improvement. But interestingly, if you take the scores assigned by those readers and you run it through the sonogram, the sensitivity improves to 99.6%, which is actually better. And the specificity jumps all the way to 51%. And the total area under the curve and the partial area under the curve all get better. Now, what this shows is that the idea that maybe there was information overload, that there was more information than the radiologist could deal with without the help of machine learning is true. When we apply the machine learning to their good scoring, we get a much better prediction of the likelihood of malignancy or false negative rate. Now, this is the sonogram applied to an outside database, which was not involved at all in training of the sonogram. This is the Maestro study from Europe. There were 213 reads by site radiologists, and it only included 4As and 4Bs. So by definition, the sensitivity was going to be 100%, the specificity was going to be 0%. So they had a 41.1% specificity with OA, but there was a 4.5% loss in sensitivity. So you can see that the specificity at 98% sensitivity was 22.7%, not what we'd like. But when we applied the sonogram to the scores assigned by these radiologists, then the specificity at 98% sensitivity went to 49.4%. The total area under the curve improved, and the partial area under the curve improved a lot. So again, this shows that they were scoring well, but it was a lot of information. It was hard for radiologists to know how to exactly convert that to predicted likelihood ratio, predicted likelihood of malignancy or false negative rate. And again, remember that BI-RADS, that function, predicting a likelihood of malignancy or false negative rate, is a semi-quantitative predictive biomarker function. Remember that BI-RADS only functions as a qualitative diagnostic, just at finding the 2% border, and we subjectively assess likelihood of malignancy above or below that. Now, we have a very brief example of how the sonogram performs in the real world from the post registry study that's going on right now. Here's a BI-RADS 5 small nodule on ultrasound and on the mammogram. And on OA, it's intensely positive. And what I want to show you is the robustness. These are the sonogram scores assigned by the OA feature scores and ultrasound feature scores assigned by the site on the left and by me on the right. And everywhere I put pink is where we disagreed. And we can see that we disagreed in 5 of the 10 scores, but only by 1 in 4 of the 5. Only one of the scores was there a difference of more than the 1 between us. But what I want to show you is the robustness of the sonogram, because the predicted likelihood of malignancy, the mean predicted likelihood of malignancy is 95% for both the reader and me. And the only difference is in the scores that the site radiologist assigned gave us a little wider 90% confidence interval. The other one I want to show you is a classically benign nodule on mammograms, a probably benign nodule on ultrasound, benign findings on OA. Notice that there's a red capsular vessel and acutely branching internal vessels. That's normal. We can see again that the site scores differed from mine in 5 of the 10, but in no case was the difference in score more than 1. And you can see that in both cases, the 90% confidence interval is so narrow you can't even pick out 2 lines, and it's exactly at the mean, which is about 0.1%. So the entire 90% confidence interval is to the left of a 0.5%. You know, this is one that you could possibly consider BI-RADS 2. Now, interestingly, 3 of the first 5 proven fibroadenomas had false negative rates where the entire 90% confidence interval was below a 0.5%. So in the Netherlands, they tend to biopsy BI-RADS 3. So it could be significant if you could call something BI-RADS 2, because maybe then they wouldn't biopsy it. Now, this just shows the subjective assignment of likelihood of malignancy, or PPV3, in blue, versus the centigram predicted one with the scoring system. And the green shading represents the ACR PPV benchmark ranges for each of the categories. And what you want is for the line to be inside that green box as much as possible. And you can see that with the centigram and OA, they get closer. Now, we were approved, the FDA approved OA as a qualitative diagnostic biomarker. But an important thing is, how do we change the diagnosis? So we can see that for benign masses, if we call it BI-RADS 3, we could downgrade a net 20.6% to predicted false negative rates that were compatible with BI-RADS 2. And if we look at 4As, which is where most of the gain comes, you can see that a net 35.9% could be downgraded to BI-RADS 3 or 2. The other thing is, you want to show that malignant lesions, you increase the likelihood of malignancy. So you can see that these are false negative prevented, where we had red is what is predicted with ultrasound, BI-RADS 3 with ultrasound. And you can see that a net 40.8% of those were upgraded to 4A or higher with OA. And even at 4A, we could upgrade to 4B, and 4B could be upgraded to 4C, and 4C could be upgraded to 5. So what you're seeing is a general tendency to downgrade benign masses and upgrade malignant masses. Now, these are predicted likelihoods of malignancy for different kinds of cancers, different subtypes. You can see that they vary. And that suggests that maybe OA could be used as a prognostic biomarker. And we've actually published an article on that. Bashak Doan from UT Southwest published an article using OA for that purpose. This is a triple negative on the mammogram. Here it is on OA. It's got a lot of internal and boundary zone features. This is a luminal A. It's pretty much negative internally, but very positive in the boundary zone and peripheral radiating vessels. And here's the Doppler on that case. Notice that the Doppler is stone cold false negative, but you know, we would assign maximum scores of 6 out of 6 for boundary zone, 5 out of 5 for peripheral zone on OA. Now, these are all luminal A's. Notice that there's very little inside, but a lot of boundary zone and peripheral zone activity. And these are triple negatives. You can see there's a lot of internal boundary zone activity, but no peripheral zone activity. So if I show you a triple negative and a luminal A, top to bottom, which is luminal A and which is triple negative. Well, the top is triple negative because it's positive internally in the boundary zone, but doesn't have peripheral zone findings. And the bottom is luminal A because it has no internal findings, but a lot of boundary zone and peripheral zone findings. And again, another pairing. Again, the top one has a lot of internal features, the bottom one no internal features, the bottom has a lot of peripheral zone features, the top no peripheral zone. So the bottom is going to be luminal A and the top is going to be a triple negative. So that's a quick summary of OA. These are several articles that are written. They're on our website at www.senomedical.com, and we're open for questions.